CanCOVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Hello, everyone. Welcome to today's CanCOVID speaker series event. My name is Susan Law. I'm the managing director at CanCOVID. And the speaker series is something we do to help bring sort of emerging evidence to the scientific community and others who are members of CanCOVID, including some industry, patient, clinical partners. And we're delighted for anyone else to join us as we get together for these weekly sessions. Today, I'm very delighted to introduce to you Professor Kathleen Rice, Kate Rice, who is an assistant professor and Canada Research Chair in the Medical Anthropology of Primary Care, based at the Department of Family Medicine at McGill University. Thanks so much, Kate, for joining us today, and I will turn over to you.
Thank you very much, Susan, and thank you everyone for coming to my talk. So as you can see, the title of my talk is Increased Use of Birth Interventions in Response to COVID-19, Findings from a Canada-wide Qualitative Study. So to provide a bit of rationale for the broader study that I'll be presenting just a snippet of today. As we all know, COVID-19 has presented us with a healthcare conundrum: how to scale back interpersonal contact, including in clinical settings, without leading to an increase in illness, injury, and death. And what this means is that pandemic healthcare reflects what has been deemed essential by policymakers, healthcare administrators, and healthcare providers. So what can we not take away without leading to illness, injury, and death? So for a medical anthropologist like me, this presents a rare opportunity to identify and critique the normative assumptions that are built into healthcare practice and that shape them, because these essentials are really laid bare. So these include questions like, what is good care? What is deemed non-essential? And how are patient dignity, choice, and autonomy being prioritized vis-a-vis workplace efficiency and safety, for example? So the broader objectives of my study: first of all, to understand Canadian women's concerns about and experiences of pregnancy and birth during a global pandemic. And I have a little asterisk next to women's because I want to point out that all my study recruitment materials have aimed to be gender inclusive. So I haven't actually used that word women or women's. I referred to pregnant and birthing people. But all respondents to my study so far have been cisgendered women. So that's the term that I'm going to be using today. I've been interested in looking at how policy changes shape experiences of pregnancy and birth. Ultimately, of course, to identify barriers to good care. I'm also aiming to capture care provider perspectives on the challenges of pandemic perinatal care. And this really is the part of the study that is still ongoing. I'm still actively recruiting there. To critically examine, of course, what care providers view as essential, and then more broadly, this will all inform theory about medicalization, care, pregnancy, and subjectivity, and allow me to critically examine the assumptions about pregnancy and birth that are built into healthcare policy. So the methodology and methods for this study: it's a descriptive qualitative study. I have interviewed 68 women who have given birth across Canada during the pandemic, and I mostly stopped recruitment there now, with the exception of a few specific groups, for instance, people in northern communities. I have also interviewed 14 care providers, and this is the part, as I said, that is really ongoing. So this is unfinished. Recruitment has been online, and these interviews have all taken place remotely, and they've been digitally recorded and transcribed verbatim. Me and my collaborator, Sarah Williams at the University of Toronto, have been analyzing this material through systematic analysis, which is an approach to qualitative data analysis that is ideal for large data sets like this, and also really useful for exploratory research in an area where much is unknown. And it allows for a balance between a focus on the actual research questions and the themes that are produced through analysis. We take a social constructionist standpoint, meaning we view birth as a biosocial phenomenon. We view biomedicine as a cultural system, as both a system of knowledge and a system that entails power structures that shape healthcare practices, the relationships between people who are bound up in the healthcare system, and the kinds of care that people get. A bit of demographic information on the study participants. So they range in, this is now the pregnant and birthing women specifically, they range in age from 22 to 43 years with an average age of 34. You can see that there's a real spread in terms of which pregnancy this has been for these women. The majority, well, no, more were first-time mothers than anything else, but we also have 23 second time, all the way up to 2 fifth viable pregnancy, and 4 people who had recently given birth to twins, and 14 participants identified as members of ethnic or racial minority groups. I'm not going to go through this slide number by number. What I want to draw your attention to here is, first of all, that we have a pretty even split between people who gave birth in academic or community hospitals. The number of people who, 2 of the 3 people who had home births, they actually made that plan in response to pandemic concerns. So they had planned to either give birth at a birth center or in hospital, and change their plans to try and avoid being in a hospital during the pandemic. And the number of people who delivered at a birth center is much lower than what had actually been planned. But in a lot of municipalities across the country, standalone birth centers were closed for long periods of time during the pandemic. So that option wasn't available. Mode of delivery, you can see we have a mix of vaginal births and C-sections. And the majority of study participants were followed by obstetricians, but we also have 12 that were followed by family doctors and 12 by midwives. This map shows you where in Canada the participants have been located. So you can see it is in most provinces and territories. And the community sizes here, these are criteria that are determined by StatsCan. Healthcare provider type. You can see why active recruitment is ongoing here. I definitely would need to recruit some more OB-GYNs and family physicians. So today's focus. We did not expect to find this, but our data pretty clearly shows an apparent reliance on birth interventions, for example, cesarian sections and induction of labor, in response to pandemic pressures and stresses. So these are both stresses on the part of pregnant people themselves and also on their healthcare providers. And I'm going to provide you guys with some data to illustrate this. I apologize in advance that these findings are quite text heavy. That is the kind of data I work with, and I have tried as much as possible to be concise. So theme 1A, perinatal care being scaled back. Now, what I mean by this is that a lot of appointments have taken place remotely for study participants, and they've had a lot less face-to-face contact with their healthcare providers. So this interviewee here, this is a typical experience, except that this person is actually a nurse. So she's better able than many pregnant people to monitor her own pregnancy. So as she said, at least 2/3, maybe 3/4 of my visits until the 3rd trimester were virtual via video call. I noticed that I wasn't gaining weight myself. I wasn't going into the clinic and weighing every time. I just remember there being a lot more checks, a lot more physical exam stuff during my first pregnancy. This time around, I felt like the onus would have been on me to identify anything weird going on. I consider this a related theme, reduced care options in hospital. And what I mean by this is there were the options that were available to people who wanted to give birth in hospital to, for instance, manage pain and advance labor were really scaled back due to pandemic concerns. So things like nitrous oxide was banned in many hospitals out of fear of aerosol transmission of COVID-19. Baths were closed and women were generally confined to their rooms, meaning things like walking up and down the hallway, trying to manage pain and advance labor through movement were restricted as well. And what this meant was more people chose things like pain management sooner because they felt they didn't, or narcotic pain management sooner because they didn't feel that they had any other options. So as this woman said, given the lack of availability of any kind of pain management, I had to have an epidural. I'm grateful that exists. It's just not what I had hoped for. I'd hoped to use other types of measures. I'd hoped to sit in the tub with warm water and take showers and be able to walk up and down the hall. But you're confined to your room, so you can't really walk around. And finally, and this is, I think, the most serious one, postnatal care being really scaled back. So first of all, most people felt that they were discharged from hospital sooner than they had in previous pregnancies, for instance, for people who had given birth before. So as this woman said, I felt like with my first, they were trying to convince me to stay longer in hospital. And with this birth, it was kind of like, nah, you're fine. It's okay. Don't worry about it. Go home. Now, you might think that this is because this is a second-time mother, and therefore they had more confidence in her ability to manage at home on her own. But this interview actually has an unruptured brain aneurysm and delivered both of her children via scheduled cesarian, I guess in an effort to keep that aneurysm from rupturing. So she had a surgical birth. And I also collected some stories like this. This was a full 3 months after she'd given birth when I interviewed this woman. So she said, I'm still not that healthy and the follow-up isn't that great. My 6-week postpartum checkup, for stitches was a phone call. Yeah, I thought I had an infection. So I called the OB office like once every couple of days for about 4 weeks. And they kept on saying, we'll get back to you. We'll get back to you. We'll get back to you. So I was finally able to get a hold of my family doctor who gave me a prescription because I ended up having a uterine infection. And since then, I'm still trying to get blood work done because for some reason, I still can't get up holding my daughter. I just have zero strength, zero energy, and just waiting to get in for blood work for that. Now I'm gonna move on to the real meat of my argument, and that's the increased use of interventions. First of all, patient perspectives on this. This is my longest quote. So this woman said to me, my obstetrician said, FYI, it just so happens that I've got a spot for an induction if you'd like to go on Saturday. I was like, you know what, let's do it. Because with COVID-19, I just wanted to get him out and make sure we were home safe. I think I was just so tired, so over it at the end, and so sad of being kind of isolated. But the doctor said, listen, I have this spot if you want an induction, and we want to get him out. It's up to you. I think that mothering instinct kicked in. And if I had to wait another week or 2 weeks and the numbers were outrageous and the hospital was inundated with COVID-19 patients, would I want to be there at that time? Probably not. So I thought I would just take that induction spot. My obstetrician said that the baby was healthy enough, he was term enough, and he could be out and managed without a NICU stay. So this particular woman was thrilled with the care that she received, was really happy about how her birth had turned out. But she does voice a very common concern among many of the women that I have interviewed, and that was fears of that the pandemic might escalate to a point that it compromised their own safety in hospital or that of their baby, and then making decisions, for instance, about birth interventions in an effort to mitigate that fear. One of the biggest fears was fear of giving birth without a support person, usually the person's partner or spouse. That happened at, as many of you know, happened at one hospital in Montreal, and it happened, for instance, in New York and some other large cities that have been heavily hit by COVID. And the fear that that might happen was a motivator for many women to push for inductions. So we can see here, this woman said, if I'm induced and we're in hospital, my husband can be there from the time I'm induced until 1 hour after delivery, and then he has to leave. If I naturally go into labor, I actually have to go into triage into the hospital alone, so he can't come in with me. I have to go in alone and get assessed. If I'm in labor, then he's allowed to enter the hospital only when I'm actually ready to deliver. So this woman had pushed for and received an induction to try and mitigate this fear of going into the hospital alone. She was a second-time mother who had had a very fast and uncomplicated vaginal birth with her first child, and she had not been induced at that time, but she wanted to be induced this time because of her COVID concerns. And finally, I have wondered if the discussion among the surgeons and the other medical professionals to get my son out when they did, they knew what was coming. And I sometimes wonder if they were like, okay, he's big enough, he's healthy, we could just put her up in a room, but we could also just take the baby out now. There were discussions among the nurses, and people were talking about it in the hospital, that things were going to change quickly. As soon as we got home, things started to lock down, borders started closing. So I wondered, I say emergency C-section. It wasn't an emergency, like if they don't get him out, he's not going to survive. And there was no harm to me either. They were like, okay, we could take him out or we could wait, but we might as well just take him out now. We know he's big. I sometimes wonder if that was a consideration because they knew things were about to change. Now, that woman is, of course, speculating. So you might wonder, what do healthcare providers have to say about this? This is a direct quote from an obstetrician in Montreal. So this obstetrician said to me, in the first wave of the pandemic, as things were building, like before things were getting bad in Montreal, we were starting to be like, well, numbers are climbing and we've got no one in our hospital right now. Let's just do an induction. And similarly, so this person is a doula, but they are also a doula trainer, run a lot of like perinatal programming in Montreal. This person has a real solid grasp of the landscape of pregnancy and birth in this city. And what she told me is we're noticing a tremendously high rate of inductions, which is problematic. We're seeing a lot of due dates changed according to late ultrasounds, which is not okay. It's not evidence-based. We're seeing a lot of, oh, you're 30 and 9 weeks. Let's just get this happening. We're hearing a lot more stories of coercion because we're not there to witness it and to amplify the voices of our clients. So we're hearing some pretty challenging stories. We're also hearing great stories, but we're definitely seeing a bigger push towards technocratic birth. So what do I make of this? First of all, hospitals in Canada have scaled back hands-on care before birth, during labor and delivery, and postpartum. That is pretty clear. Pandemic pressures and stresses motivate some women to choose birth interventions that are not medically necessary. And pandemic pressures and stresses may be motivating some care providers to encourage interventions that are not medically called for. Some participants chose interventions out of fear of giving birth alone. This is not a good reason to choose an intervention. Because all interventions entail risk and can set in motion a sort of escalating ladder of requiring further interventions. The overuse of interventions is widespread globally, and it's condemned by health regulatory bodies like the World Health Organization, for example. These findings also confirm early reports from the European Commission for Disease Prevention, which state that there's been an over-medicalization of childbirth in Europe during the pandemic. But to my knowledge, this is the first data that we have from Canada that shows this. So pandemic care priorities appear to entail proactive use of interventions and efficient health system flow. Pandemic birth in Canada is characterized by heavy intervention use, limited non-medical support, partner support, doula support, scaled back prenatal and postpartum care. And there's strong evidence that all of these are harmful. And of course, they feed into each other as well, because if you have limited care in the prenatal period, you might be less equipped to deal with problems that could arise in the postpartum period. So what do I suggest, or what do we suggest? Pregnant women need more information about interventions, both what they entail and the risks, both what will happen, like what does it mean to be induced, for example, but also what are the risks associated with that. No one in my study voiced any concern about that whatsoever, and I think that it's because most of them didn't know. They're also less likely to receive this information during a pandemic because care has been scaled back. A guaranteed support person, a support person has to be guaranteed. People can't be imminently going to give birth fearing that they might have to do it alone. We have a lot of evidence that this is especially crucial for certain groups who face systemic racism within the healthcare system, for instance, Black and Indigenous people, and people for whom there's a language barrier. I would call for a rethinking of what is and is not viewed as perinatal care. Is support essential? I would say so. No movement at all. I'm not sure about that. No pain relief except for epidural and opioid narcotics. No bath or shower. So here are just some references that support what I have been talking about. If you'd like some more information, in particular, this paper here, which just came out in CMAJ Open last month, it goes in much more detail into the reasons why limiting the presence of a support person has harmed certain groups of birthing women in particular. And this is new research, so I would very warmly welcome questions and feedback. Thank you very much.
Thank you very much, Kate. That was just wonderful. Excellent research and very timely and a really important topic. So we do have some questions already in the chat, and I'll just go through these with you. So in your study, did you track whether the mothers were vaccinated or considered vaccination, and if not, what they thought about vaccination? And how aggressive were the mothers' healthcare providers in encouraging vaccination? So did this come up in your study?
So that's a great question. And it is reminding me now after the fact that I should probably have presented a timeline for when most of these interviews were done. So the study started in July of last year, and most of the interviews took place between July and October, meaning vaccination wasn't really on the table for any of these women. And it also, at the same time, it wasn't yet known that pregnant women are at increased risk of serious complications in the event of COVID infection. No one spoke about discussing vaccination with their healthcare provider. I think if I were to interview some people who have given birth in the past month, for instance, then that would probably come up a lot.
Thank you. Second question, when do you think that the more full spectrum of pain management options might be available again, such as tubs, nitrous oxide, other forms of pain management?
So hopefully soon. The fact that nitrous oxide involves breathing means that I think there's a lot of reluctance around it for that purpose. At the same time, I didn't present this particular data because there's a huge amount of data in this study, but wearing a mask while pushing was something that most people were told they were going to have to do, and something they were really worried about. And most of them didn't even end up having to do that in practice. That wasn't well enforced. So if hospitals were not actually enforcing that, hopefully kind of a pragmatic approach will prevail soon. And they'll say, well, if you're not going to wear a mask, you might as well use the nitrous. Tubs, that I think that should happen fairly soon. My understanding was it was more the concern was not that people would get infected in the tub, but the traffic to and from the tub and the time needed to clean the tub would take away from a potentially slammed healthcare system. And now that our numbers are going way down as vaccination rates rise, hopefully that time pressure is already being relieved, and so someone will be able to clean the tub.
Thank you. Two questions from Katie, but I'll just take them one at a time. So the first is, can you speak a bit more about the stories or perspectives shared by the women of color in your sample of participants?
Sure. So this is really interesting, actually, and this is part of the reason why I'm trying to actively recruit more participants. Honestly, I was surprised at how similar their experiences were to other people across the country. What I've actually been seeing is that a lot of what's long been documented in terms of systemic discrimination, feeling of neglect and being alone and being not heard. What has happened is that has now extended to people in privileged positions as well. It's been so the COVID has almost leveled the playing field in a way that is wholly negative. Obviously, we want to eliminate that systemic discrimination, not extend the outcome of that more broadly. Interestingly, the two, for instance, Indigenous participants in my study are in a socioeconomically very comfortable position. They both work in lucrative, high prestige jobs. So I think they have been able to draw on that. This is a piece that I actually want to recruit more data on, because I don't feel yet that we can comment on it the way that we would like to.
Sorry, put myself on mute there. And secondly, then from Katie, for those women who had medically unwarranted inductions, did they feel that they participated in the decision making, or was this something they felt pressured to do?
So it varied. There were some people, like the woman who I presented that quite long quote from, she had a successful induction in the sense that it started labor, that it progressed fairly quickly. She had a vaginal delivery. it didn't escalate to a failure to progress that resulted in a C-section. People like that were generally fairly happy. And some of them had, as I said, had pushed for induction themselves and encountered care providers who seemingly were only too willing to agree to that. And then there were a group who said things like, I felt like a trapped animal. And then my husband had to leave 2 hours after I gave birth, and I was recovering from a C-section, recovering from this traumatic experience, and I was alone with my baby in hospital for 48 hours, and I've never had a baby before, and I couldn't even pick her up without help, and I didn't have help. So it was a real split based both on how the birth progressed and also the degree of agency that the woman felt she had in requesting or refusing that intervention in the first place.
Great, thank you. I'd be curious to hear about themes that have to do with personal perceptions or expectations, comparing clinicians versus patients for care during a pandemic, and compare when there was little known versus more information available about COVID risk or transmission. So it's about that comparison, I think, of perspectives between clinicians and patients.
So that's a wonderful question, but because I'm really still actively recruiting healthcare providers, and as you saw, I've, for instance, only interviewed 2 obstetricians so far, I don't really feel that I can make that comparison yet.
To come. Great. In your cohort of pregnant women, did any of them become COVID-19 positive? And this question is really to guide future OBGYN practices.
Yes. They did. I interviewed a number of women who have gotten COVID. And actually, this does link back a bit to Katie Dainty's question about women of color, although that might not be quite the appropriate word. By chance, I've interviewed quite a few Orthodox Jewish women. And as some of you may know, that particular community, for a range of unfortunate reasons, was very heavy hit, especially here in the Montreal area early on. And many of them contracted COVID. So their experience of having COVID during the pandemic and the care they got really intersected with ideas about that community in particular. At the same time, that is a community that tends to have large families. So the experience of being pregnant and giving birth was not at all unknown to those women. So they had less stress about it in that sense because it was a familiar experience. But at the same time, they were, they had 5 children at home and they had COVID, and their father-in-law also had COVID. So they had a huge care burden to take on in addition to looking after a newborn.
Great. I might add a tag on to that just from me, just a little bit curious about your dissemination of the results and if OBGYN practices are going to be sort of the target for some of that.
I hope so. In fact, I intend to make it so. Unfortunately, they don't tend to come across in a very positive light in most of the narratives that I have collected. So the real impetus is going to be on me and my collaborators to present strong evidence of what was not done well and what could be done better. And of course, present some real options for what that would look like. I have found that there's been a lot of interest from my colleagues in the medical school at McGill who are in obstetrics and gynecology. So I find that really encouraging that they're very interested in these findings and actually agree with a lot of what I'm saying, but have said, especially at the beginning, there was so much that was unknown. It was so stressful. Everything was changing so much. Even the policies coming down to us were changing. We didn't always know what we were supposed to do in any given moment. And of course, that carried into the care that we were able to provide.
Great, thank you. Next question is about whether or not you detected in your study a change in birth weight average in comparison to previous study. Wasn't measured. Yeah.
No, that we weren't measuring that. So I can't say.
Okay. There might be others that have, so it'd be interesting to watch. Yeah. Good. Another question from healthcare perspective, shouldn't the pandemic policies be targeted to the practice, in this case OBGYN, rather than implying universal policies for the whole hospital? Last week at Emerge, I saw a term pregnancy woman walking herself, and it gave me shudders. So just curious about your notion of how some of these policies for restrictions have been targeted for entire hospitals versus particular departments.
So that's a really interesting question. If you have an opportunity to look at the paper that we just published, we're really advocating for a more tailored approach. One of the things that we really critique is this kind of umbrella policy for everyone, when the needs of different groups are different and the jobs that they do are different. So of course, I don't think that the rules for should apply across, some rules must apply across the whole hospital, but some have to be tailored towards the specific work that particular healthcare providers do. At the same time, these pregnant women and birthing women have all had to follow the same policies when their needs are not all the same. Somebody who has just had a C-section after a 36-hour-long failed induction, so I hate to use that term, but whose partner has to leave 2 hours after they give birth, their needs are very different than someone who's just had their third smooth, quick vaginal delivery. Someone who has pre-existing mental health struggles, even if they're very well managed prior to the pandemic, is probably not going to cope very well at home with absolutely no help and support in their household. And we're really advocating, for instance, for healthcare providers to speak to those people specifically and say, yes, the rules, well, they have changed now in most places, but yes, the rules said you're not allowed to have anyone in your home, but you're going to need somebody. And your mental health is also a health issue, and it is also important. And you're not going to be able to look after yourself or your baby potentially. So let's think about who would be a wise and practical choice for you to have them come in and provide that support. Because what we've been seeing is people have been reaching out when they've reached a state of desperation, and they usually reach out for the person who is immediately available. And that's been an elderly parent who, until recently, with the vaccination rates increasing a lot, that's been a person that is really vulnerable, when with prior planning, they could have, for instance, had a sibling who could have taken time away from work, or a close friend or something like that.
And sorry, there are some other questions, but I'm going to jump to the very last one, which is just about around information and support and what women actually need or have suggested that they would appreciate. Can you talk a little bit about efforts to increase knowledge synthesis and dissemination in birth centers and primary care?
Yeah, that's a great question. So it's been hugely variable. I would say a big shout out to St. Mike's Hospital in Toronto for their pandemic pregnancy guide, which a number of women that I interviewed have found to be a wonderful resource. So it's been more institution by institution. For instance, that collective that the doula who I cited, who I quoted, her group has done a huge amount of outreach as well. So there have been people in different places within the system that have really made an effort to educate, and other people who haven't had access to that have been without. I would say the one thing that has really not worked remotely or via Instagram or whatever has been breastfeeding support. Even like a Zoom, if you're struggling with breastfeeding, trying to figure out the latch via a Zoom call hasn't really worked for people.
That's great. We're a little past time, so I'm going to end it there. But thank you very much, Kate, for your time today, and a wonderful study. And good luck with the rest of your recruitment and all of the rest that comes with that. So congratulations to date. And I would just like to let everyone know that we are anticipating that we'll have a speaker, a little bit of a glitch for next week, but hopefully you can stay tuned, and we'll let you know who's going to be speaking next Tuesday. And wish everyone a very happy Canada Day in whatever way you'd like to support that or celebrate that or not. And thank you again, everyone, for participating. Great session.
Thank you, Susan. Thanks all for coming.
Bye.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCOVID or joining our Pan-Canadian COVID-19 research network, please visit our website at www.cancovid.ca.